Hello all, welcome back to Dental Notes and Mnemonics. Today we are going to discuss about black triangles. So let us begin with the interdental papilla first. The interdental papilla is a gingival tissue that fills the space between two adjacent teeth, forming the base of what we call the gingival embrasure. Its presence is essential not for aesthetics but also for speech, protection of periodontal tissues, and preventing food impaction. When this papilla is lost or fails to completely occupy the interproximal space, it gives rise to what we clinically call an open gingival embrasure, or commonly termed to as black triangles. Thus, the black triangles are defined as visible triangular spaces between adjacent teeth due to loss or absence of interdental papilla. They present as dark spaces near the gingival margin and can affect aesthetics, phonetics, and periodontal health. The cause of papilla loss can be easily remembered using the mnemonic papilla. Periodontal disease is one of the most common causes where bone loss reduces the support for interdental papilla. Brushing and food impaction can damage the interdental papilla, leading to black triangles, often linked with cervical abrasions. Shape affects the interdental papilla. Triangular teeth have high scallops, are more prone to black triangles. Square teeth have flatter scallops with better papilla fill, and circular teeth provide intermediate aesthetics. Iatrogenic causes like over-aggressive scaling or surgical trauma may directly damage the delicate papillary tissue. In addition, the loss of alveolar bone due to age-related resorption gradually reduces the papilla height. Certain local anatomical factors, particularly a thin gingival biotype, makes the papilla more vulnerable to shrinkage. Tarnow classification is used to describe the loss of interdental papilla. In a normal situation, the papilla completely fills the interdental space and reaches the contact point, giving an aesthetic appearance with no visible black triangles. In class 1 loss, the tip of the papilla lies between the contact point and interproximal cemento-enamel junction, leading to slide open space. In class 2 loss, the papilla tip is at or below the interproximal cemento enamel junction, but still above the facial cemento enamel junction, showing a more noticeable black triangle. In class 3 loss, the papilla tip is at or below the facial cemento enamel junction, representing severe papilla loss with large unaesthetic space. Tarnow predicts papilla fill based on bone to contact distance, whereas Cardaropolis papilla presence index assesses papilla clinically, scoring from 1 fully present to 4, which is complete loss with cemento enamel junction visible. Clinical evaluation involves probing papilla height relative to contact point and assessing the radiographs. If the distance from the contact point to bone crest is less than or equal to 5 mm, papilla usually fills. More than 5 mm often leads to black triangles. Management of black triangles and loss of interdental papilla requires a multidisciplinary approach. The management requires non-surgical and surgical methods. Non-surgical methods which preserve or mask the papilla without incision, and surgical methods which reshape or reconstruct tissue through flaps or grafts. Prevention is the first step. Soft bristles, toothbrushes, floss, and properly sized interdental brushes help maintain papilla and prevent trauma-induced loss. Methods mainly involve the use of gingival prosthesis, either removable or fixed. Gingival veneer is a removable prosthesis that masks black triangle or gingival recession by replacing missing papilla with gum-colored material. It is non-invasive, aesthetic, cost-effective, and useful when surgery is not feasible, though it requires regular cleaning and maintenance. Gingival prosthesis is indicated when the space between the contact point and papilla is greater than 5 mm and when surgical procedures are not suitable. They are not recommended in the patient with poor periodontal health, compromised oral hygiene, or high risk of caries. Advantages is being it's non-invasive, economical, easy to repair, and ability to provide splinting support. And disadvantages are the need for patient compliance, the risk of food impaction, bacterial growth, and eventual discoloration of the prosthesis. These prostheses can be fabricated from various materials such as auto polymerizing and heat cure acrylic resins, rigid or flexible copolymamides, and soft silicon materials. Restorative techniques aim to modify tooth shape and contact points using composites, porcelain veneers, or crowns. By creating broader contact areas and smoother emergence profiles, restorations help close the black triangles and improve aesthetics. In some situations, pink restorative material are also used to mimic the lost gingiva, providing an immediate and minimally invasive option. The goal of orthodontic treatment in black triangles is to make the root parallel and position contact points correctly. A brightening or mesial movement of incisor relaxes the fibers between them, helping the papilla to naturally fill the space. Proper bracket placement is critical. Bracket should follow a long axis of the tooth, as error can cause root divergence and worsen the triangle. Radiographs must be checked before bonding to confirm the root alignment. Tooth direction also matters. Lingual movement thickens the gingiva and moves the embrasure upwards, while labial movement thins the gingiva and shifts the embrasure downwards, creating black triangle. Bone support also influences papilla fill. Closing a diastema compresses soft tissue, improving the papilla. An important adjunct is interproximal enamel reduction, removing 0.5 to 0.75 mm of enamel, especially in triangular teeth, broadens the contact area and moves it slightly gingivally, reducing the black space. Research show that mild crowding and treatment duration do not strongly influence black triangle formation. Instead, the key factors are root parallelism, bracket placement, and tooth reshaping. Interestingly, crowding under 8 mm and the duration of orthodontic treatment do not significantly affect the occurrence of black triangles. Surgical management of lost interdental papilla can be broadly classified into tissue preserving and tissue reconstructive techniques. The main difference is simple. Tissue preserving flaps protect what is already there, while tissue reconstructive flaps rebuilds what is lost. Let's talk about the main surgical approaches. There are three approaches. First of all, the papilla recontouring approach. This technique reshapes the soft tissue contours to reduce the black space, black triangle space. Papilla preservation approach maintains the papilla and helps shift the gingival margins apically. And papilla reconstruction, this is more advanced method where the techniques such as pedicel flaps combined with papilla preservation are used to rebuild the lost papilla. Papilla preservation techniques. The classical papilla preservation flap is a standard approach, ensuring that interdental papilla remains intact while gaining access for regenerative therapy. The modified papilla preservation flap refines this technique to allow better closure over grafts and membranes, while simplified papilla preservation flap is specifically designed for narrow interdental spaces less than 2 mm in size. Other approaches like envelope type flap provide access without vertical releasing incisions, minimizing trauma, and the semilunar coronally reposition flap allows coronal repositioning of gingiva in a tension-free manner, making it especially useful in aesthetic zones. When the interdental papilla has already been lost, reconstructive techniques are required to restore aesthetics and function. These include pedicle flaps where adjacent gingival tissues is rotated or repositioned into the defect. Autogenous osseous with connective tissue graft which provide both hard and soft tissue bulk for rebuilding lost structure. Microsurgical augmentation performs under magnification, enhances precision and vascular supply, improving the aesthetic outcome. More recently, injectable fillers such as hyaluronic acid has emerged as minimally invasive alternative, especially in cases where surgery is not preferred. As per Tarnow's classification, when the distance from the bone crest to the contact point is equal or less than 5 mm, the papilla fills the space almost 100% of the time. When the distance is 6 mm, the fill drops to 56%, and at 7 mm or more, the chance of papilla fill is around only 27%. Prognosis is favorable in mild to moderate cases, especially when triangular crowns can be corrected or orthodontic intervention is possible. So this was all about the black triangles in its management. I hope this video gave you a clarity on causes, classification and treatment options. If you found this video helpful, do give it a like, share it with friends and colleagues, and subscribe for more videos like this. Thank you for watching. I'll see you in the next video. Till then, bye bye, take care, have a nice day.